Good afternoon, everyone, and welcome to the Health Research Board Trial Methodology Research Network webinar series. Today, our webinar is entitled Network Meta-Analysis for Complex Interventions in Health, and it is hosted by Dr. Chris Noone and Ms. Joy Leahy. Just a little bit of housekeeping before I introduce them further. All attendees are muted for this. If you have any problems hearing or connecting or anything, if you could type it into the Q&A function, which is just at the bottom of your screen. And if it's not showing up, if you just hover your mouse towards the bottom of your screen, it should pop up. There's also a chat function where you can chat to me or chat to the panelists, and you feel free to use that also. We will have a Q&A session at the end, and I will pose any questions to the panelists. So if you would like to type them throughout, that's fine. I will collate them at the end. So yeah, that's great. So just to introduce our two speakers today, Dr. Chris Noone is based here in NUI Galway. He is a postdoctoral research in the School of Psychology in NUI Galway, and his current position involves the application of network meta-analysis to estimate the comparative effectiveness of behavioural and pharmacological approaches to reducing blood pressure in people with hypertension. This work is funded by an IRC New Horizons grant, which is awarded to Dr. Jerry Malloy and Professor John Newell of NUI Galway. Ms. Joy Leahy is a PhD student in Trinity College Dublin. Her research interests include Bayesian methods for evidence synthesis and network meta-analysis, with particular focus on the appropriate use of lesser quality evidence, which is a very interesting area. Joy has worked on applications of these methods to disease networks such as hepatitis C, melanoma, and multiple myeloma. And her research is funded by the Health Research Board. I will now pass over to Chris and Leah and Joy. I'll start the video.
Okay, hi everyone. I'll just share our slides now. Okay, so hi, I'm Chris Noone. This is, what do you want to slide in there, Joy? So thanks very much for having us, Rachel and Sandra from the team we're delighted to be able to give this webinar. So this is part of a project that's funded by the New Horizons scheme from the IRC, and as Rachel was saying, Dr. Jerry Malloy and Professor John Newell are the PIs in that project. So that we do have a kind of a training component as well as the research component of this project. We have a training component. So this webinar is kind of the start of that, but we'll also be running some workshops on network meta-analysis, and I'll mention those again at the end of the webinar. So just to give a brief outline of what we're going to talk about, I'm going to talk briefly about what network meta-analysis is, and a very brief overview of how it works, and then discuss important considerations for applying network meta-analysis to complex interventions. And then Joy is going to take over and talk through a kind of step-by-step example of how network meta-analysis are conducted and some important statistical and methodological issues that need to be considered. Okay, so you may not have ever read a paper that included network meta-analysis. It's relatively new. I suppose the method was developed about 20 years ago, and it took about 10 years to make its way into mainstream medicine, and then it's only in the last 3, 4, 5 years that it's being used more often in kind of broader fields of health and coming into health psychology, which is the field that I work in. And it's being used in clinical psychology to an extent as well. So as I said, you may not have come across a paper that included a network analysis, but in the past few weeks, I'm sure you all saw these headlines focusing on the effects of antidepressants. And these headlines were actually generated by a study by a team led by Andrea Cipriani, who's a statistician who's done a lot of work in the area of network analysis, and they basically brought together a huge systematic review of 21 different antidepressant drugs. And what network analysis allows you to do is to, where before we would have had to just look at pairwise comparisons between one of these drugs and placebo, or one of these drugs and another drug, you can integrate the information from all of the different trials that would have included these drugs. And it was the results of this study that generated all of these headlines. So it's just an example to show that network meta-analysis is now kind of a mainstream method, and it's making its way to the headlines. I suppose one thing to note about that network meta-analysis was that it did only include drugs, and there are a lot of other ways of treating depression that could have been included possibly in the network as well. There's some good work in the area of social anxiety, where trials including drugs, therapeutic approaches, and then combinations of drugs and therapy were included, and that produced results suggesting that that combination of drugs and therapy were probably the most effective approach. Okay, so I alluded to it there, but what is network meta-analysis? So typically, meta-analysis has been used in the comparison of one intervention to another intervention. Usually, we would gather using a systematic review, a collection of trials that had compared an intervention we were interested in to either a standard intervention or placebo or usual care, something like that, or some sort of control condition. And so the graphic in the top right of the figure there, looking at the comparison of the conditions A and B, that's kind of the standard pairwise meta-analysis that we're used to. And this is good at telling us like the effect size between one thing and another, or in clinical terms, whether something works better than something else. But it doesn't tell us what works best. So network meta-analysis is a generalization of this approach, which allows us to include multiple conditions or multiple interventions, even if they haven't been compared within the same trial before. So if you see at the bottom of this figure, we have comparisons of condition A and condition B. So that could be, A could be kind of treatment as usual here. B could be one particular intervention, and C could be another possible alternative intervention. So these may have both have been compared to usual care, but not to each other in intervention. But network meta-analysis allows us to derive an effect size between these two alternative interventions, the B and C, and that's indicated by the dotted line there. And that would be called an indirect comparison, whereas the kind of traditional types of comparisons we're used to in pairwise meta-analysis are direct comparisons. So it's a really useful tool for synthesizing all of the information that we get from a systematic review, and for finding out about the comparisons between trial interventions that may not have been compared to each other before, which can be a good way of figuring out whether it's worthwhile to pursue an RCT that compares those two conditions, or those two treatments. So why is network meta-analysis useful for complex interventions in particular? Well, some of these advantages are can apply to all types of trials, but the first one would be that it maximizes the use of available evidence. So so where there are trials with multiple arms, we can include them. We don't have to lump interventions together in order to fit a pairwise comparison. We can respect differences between interventions by representing them as different nodes in a network, and it gives us comparisons between any pair of interventions within that network. So very rich information. Also because we are using both evidence from direct comparisons and indirect comparisons, this can help increase the precision of the effect size that we're deriving compared with just direct evidence alone. And most interestingly, for complex interventions, we can use it to try and reveal the most effective components of complex interventions. We'll talk a little bit more about that later. So in recent years, NMA, or network meta-analysis, has become a key component of approaches to developing clinical guidelines and reimbursement recommendations by various different national health technology assessment agencies around the world and the World Health Organization. And there's there's an argument that it represents a kind of another step in the hierarchy of evidence that comes above usual pairwise meta-analysis. So just a really simple example of how it works, and I've kind of explained this already, but just to say that network meta-analysis originated in this derivation of the simple indirect comparison. So so if we were to take the example of hypertension, and we had complex interventions focused on either increasing physical activity or reducing salt intake in order to reduce blood pressure. So these are a perfect example of where we could apply a simple indirect comparison, because these types of interventions are usually compared to just usual care. And the usual care for these patients would be the same, because they're all hypertensive patients. So the simple indirect comparison is simply derived by using the direct comparison of say the physical activity intervention and the control group, and the direct comparison of the salt reduction and the control group, and it's a fairly simple formula. So more generally, it can be expressed like this: that the indirect evidence is the direct evidence from one pair of interventions taken away from the direct evidence of the other pair of interventions. In turn, and this would be the estimates that are represented here of the effect size. So the variance of these effects of the indirect comparison then is equal to the sum of the variances of each of these direct estimates. So basically what that means is that it's a less precise measure on its own, the indirect comparison. But when we integrate it with direct evidence, which is what network meta-analysis can do, the more sophisticated models that we now have, that actually makes for a more precise effect size than the estimate than the direct evidence alone. So yeah, we can generalize beyond this direct or this simple indirect comparison to whole networks now with the more sophisticated models that have been generated. And Joy might talk a little bit more about that later. Just to kind of highlight some of the assumptions of network meta-analysis, they are really just generalizations of the main assumption of pairwise meta-analysis. So in pairwise meta-analysis, we are trying to assume that that there's sufficient similarity between all the trials that we're synthesizing in order to allow us to produce an accurate summary estimate. When it comes to network meta-analysis, we have not just trials that are similar, but also different types of interventions being compared to each other. So we need to ensure that there's what's called transitivity between these trials. So transitivity means that we need to ensure that there's an even distribution of effect modifiers across all of the different trials in our network. So effect modifiers could be things like gender or setting of the intervention, or any types of clinical characteristics that would that might interact with the actual effect of the intervention. So any of those things should be evenly distributed across all of the trials in our network. So that's just to ensure that we are that we are integrating trials that use a similar kind of sample or similar kind of patient population. And I guess the simplest kind of interpretation that I've heard of it is that you should theoretically be able to create a massive RCT that includes all of the trials in this network, and all the participants should be eligible to be randomized to any of those arms of the trial. So you can check. So transitivity is something you kind of evaluate qualitatively, but you can look at consistency, which is kind of a statistical expression of transitivity, which checks whether the direct evidence and the indirect evidence agrees. And that's something that we always have to check when we're doing a network analysis. So just quickly to look at some of the challenges in applying it to complex interventions, particularly ones that include a behavioral component. You must take care regarding the reasons why a particular behavior is being targeted, or why a particular set of behavior change techniques are being used to target that behavior. There may be reasons why different behavior change techniques or different behaviors are targeted in different trials. There might be characteristics of the participants in those trials that determine why those behaviors are being targeted. And if that's the case, that there are differences between the underlying samples in these different trials, then that would be a violation of the assumptions that we talked about on the previous slide. Another problem is with complex interventions, there's usually huge variation in the control groups used and the nature of those, and usually poorly reported descriptions of the contents of these control groups. So it can be difficult to, you can introduce a lot of variability or heterogeneity by assuming that all these control groups are the same. And unfortunately, often complex interventions can be poorly designed or with small samples, and any methodological limits that introduce bias can affect the whole network. The bias can kind of propagate through the network in ways that are kind of difficult to identify. So the ideal conditions for a network analysis is that there's an availability of both direct and indirect evidence, that the measurements of the outcomes was valid and reliable. Using standard outcome sets across trials would make network meta-analysis much easier. It's important that there's transparent reporting of the intervention methodology and the results, and also the contents of the control groups. And if there was compulsory sharing of individual level data, then that would be a huge help as well. So just to highlight some of the opportunities for using network analysis more when it comes to complex interventions, is it will give us new insights into whether and which behavioral interventions should be prioritized in healthcare. So one way you can express the results of the network analysis is through a rankogram. So what a rankogram does is it plots the probability of each treatment being at a particular rank. So the probability of this one treatment G being the best treatment is 50%, and it's quite a bit higher than all of the other treatments. So it's an interesting way of presenting results, and gives us, it's useful for healthcare decision making, and that's why it's used in health technology assessment a lot. And there's also potential for linking it to other interesting developments in the realm of meta-analysis, particularly multivariate meta-analysis, where you can use several outcomes within the one meta-analysis, or automated meta-analysis. Anyone who's familiar with Susan Mickey's work on and the kind of very ambitious human behavior change project that they have ongoing could see how a network approach to the automatic meta-analysis that they want to develop would be hugely helpful. And this approach has already been developed by a group in Paris. I just concluded a figure from them. They call it live cumulative network meta-analysis, and they've applied that within research on lung cancer. So it will allow us to analyze the contribution of specific components in complex interventions. So here's an example of, usually this is a network that would usually be represented as just a couple of psychological therapies, but it's possible to break it down into the particular components within those therapies. And Joy will mention a couple of models for how to analyze that. And then one way that health psychology in particular can contribute to making network analysis work really well in its application to complex interventions is by the application of taxonomies of modes of delivery, settings, behavior change techniques, theoretical constructs, and mechanisms of action. But these would all really help aid in the definition of the nodes within the network. Okay, so I think I'm going to pass over to Joy now to talk a little bit more about the methodological and statistical considerations.
Okay, great. Thanks, Chris. Okay, so I'm just going to speak a little bit more about the actual statistical considerations when doing a meta-analysis. So firstly, this sort of goes back to what Chris was speaking about, but one of the most important things for a network meta-analysis is to have a connected network. So in this basic example here, we have just a simple indirect comparison with two trials. Trial 1 compares drug A to placebo, and then trial 2 compares drug B to placebo. But of course, what we're probably mainly interested in here would be which works better out of drug A or drug B, because that's the decision that you're making about, which of these drugs should you give to patients. So let's say, for example, we knew that for those taking drug A, 60% were cured, and for those taking drug B, 40% were cured. So if we just knew this information and absolutely nothing else, we'd say, okay, it seems like drug A is better than drug B. But of course, we know we can't do that because there could be other things going on in trial 1. So trial 1 may be, for some reason, made up of patients that are more likely to be cured anyway. And this could be because they recruited particularly healthy patients, or it could be something to do with the setting of the trial itself. It could be carried out in maybe like an affluent area that has good access to healthcare. So then if you get sick, you're more likely to be cured there anyway. So all these things could affect the cure rate. So we need to figure out what this is in both of these trials. And the way we do this is by going through the network and seeing how the placebo got on in both of these trials. So let's say, for example, we found that in trial 1, the placebo actually did better than the active drug A. And in trial 2, the placebo did worse than the active drug B. Then in this case, what we'd be saying is, well, drug B looks to be better than placebo, which in turn is better than drug A. Therefore, we conclude that drug B is better than drug A. And we've reached a completely different conclusion here by going through the network. So it's very important to realize that, amongst other things, the probability of, say, in this case, being cured is made up of not only the treatment effect, but the effect of being in this trial. So basically, once you know that somebody's in a particular trial, there's actually a certain probability that they'll be cured even before they're assigned to one of the treatment arms. Okay, so now I'm going to go on to some real world examples. So I've got two here. So the first one I'm going to speak about is for treatments in hepatitis C. So this is work that I was involved in, and some of the main considerations here were how do we define a treatment, what do we split out, what do we keep together, and how do we work with disconnected networks. Then later on, I'm going to speak about other research by Nicky Welton and others from the Bristol group on coronary heart disease and how they modelled the complex interventions. Okay, so one of the other researchers on this project, Emma Gray, carried out a systematic review, and she identified 13 RCTs with 16 unique treatment regimens. So they're all listed here, but as you can see, a lot of them are quite similar. So within each of the different colors, the only difference between them would be something like, say, for example, duration. So here, pegylated interferon or efavirenz, the only difference was how long patients were on the treatment. And then if we look further down, say at the grey box here, it was either duration or the dosage level as well. So 16 treatment regimens would have been a lot to work with. There wouldn't have been much power. So what we did was we grouped interventions together if the only difference was duration or dosage. So then we came up with the 9 treatments that are listed here. And one of the things to note about this is that most of these treatments were one drug plus this PEG-RIBA. And then down at the bottom, the last 3 treatments all contain SOF, but they contain something else as well. So full pegylated interferon or efavirenz, or just efavirenz here, or else SOF and DIP here. So we decided to keep these separate. So then we went on to drawing the network diagram, which is shown here. And you can see that we kind of straight away run into a problem. We had this black network where most treatments were compared to PEG-RIBA, which is the standard of care. And this is a very common sort of network structure that you see. So even though, say, a lot of the treatments have been compared to each other, you could say, for example, find a comparison between, say, BOC and PURE and TEL and PURE by going through the indirect comparison. However, we had 2 treatments here that weren't connected to the rest of the network. They had been compared in a randomized control trial against each other, but because neither of them had been compared to anything else, there's no way to say, like, how did SOF and efavirenz do versus any of the treatments in the black network. All right, so then we're faced with this problem. What do we do with this disconnected network? So there are a number of different options. The first option was simply to just combine treatments. So we combined SOF PURE, which is a black network, and SOF or efavirenz. But from the beginning, through clinical opinion, we thought they were probably quite different. And then when doing the statistical analysis, we decided that they were in fact too different to be combined. So we left that approach there. The next option was to use methods for disconnected networks. So there's a couple of options for this. It was a large part of my research so far. And there are also a number of other statisticians looking at this as well. So last November, I came together with Howard Thom in Bristol and Jerome Jansen in the States. And we did a workshop at the ISPOR conference, which is the International Society for Pharmacoeconomics and Outcomes Research. So the workshop was on disconnected or limited evidence in a network meta-analysis, what can be done. So those slides are available online if people want to hear more about disconnected networks. But for now, I'm just going to focus on the third option, which is just simply to use the bigger network. So this is the advantage of minimizing any potential bias, because as soon as you include treatments that aren't randomized control trials, you are probably going to be adding in some bias. However, there is a very large disadvantage of this as well, which is that some treatments are left out of the analysis. So in this case, instead of being able to use the full 9 treatments, we can only look at the 7 in the black network. Okay, so once we decided on our network and our treatments, then there's a couple of decisions to make about implementation. So the first consideration is the outcome. So the outcome of interest in hepatitis C is usually sustained viral response, which is pretty much like a cure. So this is a binary outcome, so either you attained SVR or you didn't, and we measure this on the log odds ratio. However, in other networks, there could be other outcomes. So you could have a continuous outcome, which would be maybe like a reduction or an improvement. So a reduction could be something like reduction in blood pressure or improvement in something like physical activity. So usually this is evaluated as change from baseline as opposed to the absolute effect. Okay, and then third option could be time to event, which is used a lot in, say, in cancer. So you can have progression-free survival, which is time until your tumor grows again, or overall survival, which is time to death. So the way that they can be compared is through medians or through hazard ratios. Okay, so then next, if you're thinking of carrying out a network meta-analysis, you need to decide what software you're going to use. What I usually use is bugs. So all the results here have been obtained by bugs. So there's two options. There's open bugs or else WinBugs for a Windows machine. So this is Bayesian inference using GIB sampling. So it's done in a Bayesian setting, and it's done by this iterative sampling procedure. So there's a screenshot below, and if you look here at the blue and the red lines, that's showing the sampling procedure. So you have to write your own model for this. So it can be more time consuming, but it encourages a lot more control over the model choice and the specification. Because of the iterative procedure, the computation time as well can be slow, but if you're only doing it once, it shouldn't be that big a deal. In case you've heard of it as well, there's also a second program like this called JAGS, so just another GIB sampler. So they both use the GIB sampling method, so underlying principle is quite similar. There are other packages that can also be used. So there's a OR Studio or OR program, which is a very popular statistical program, and that can actually call bugs or JAGs directly through a number of packages. So there's OR JAGs or bugs or to win bugs. So the bugs program itself can be a little bit, I suppose, like tedious to use, but OR will allow you automate your procedures, so it's really handy. It also has other packages like GMTC, PCNetMeta, NetMeta, and FastDemon. So some of them, such as GMTC, call JAGs as well, and then other ones such as NetMeta is a frequentist package, and it's all done within OR. Finally, there are other options such as Stata, which is another frequentist package, or Stan, which is like bugs or JAGs. So in terms of which ones to use, well, I'll say first that Stata, I think, is the only one of those that you have to pay for, and a lot of the free software there is very powerful for doing meta-analysis, and I think it's quite sufficient. Then in terms of, say, bugs or JAGs, bugs has the nicer interface to use when you're starting up your models. But one downside of it is that it's not as supported a lot. So if you think you're maybe doing a lot of network meta-analysis and you'll have a lot of computing time, you might want to run it on like a cloud computing platform, such as, say, Amazon Web Services, and they only support JAGs. And I think I've come across this issue in a couple of different places. So if you want to write something and automate it, it might be easier to write it in OR-JAGs because you'll be able to use it more widely. Okay, so now just to go back to some of the results from the hepatitis C network. So firstly, what I'm going to present is the 95% credible interval for the log odds ratio. So if two treatments have the same odds ratio, or if their log odds ratio is 0, then that means they have equal efficacy. And then anything to the right here of this line with no effect means that the treatment is better than the reference treatment, which in this case is pegriba. So we see here that all the treatments are better than pegriba. And of course, since most of these treatments are pegriba plus something else, that's probably not that surprising. We see that there is large variation in the point estimates, which are the little dots, and also the lines for the log odds ratio. So there's a lot more certainty in some of these treatments that were actually in more trials than some of the other treatments below here. So by looking at this, we can rank treatments. But as Chris already mentioned, another thing we can do is use rankograms. So as I said before, bugs runs an iterative process. So the rank of each treatment is saved at each iteration, and it gives us the probability of each treatment being in each position. And then we can sum these probabilities to find the probability of each treatment being in the nth position or better. We can plot this on a rankogram. Mine will differ a little bit from Chris's, given that I'm doing a cumulative rankogram. So instead of looking at just it being in each position, you're looking at the probability of it being in that position or better. So on the x-axis, we have the position, and on the y-axis, we have probability. So if we look at, say, PROD plus ribavirin, it is 80% likely to be the best treatment. And then it's nearly 100% likely to be the second or the first best treatment. If we go down here a little bit, then there's two that sort of work together or have the same lines. That's DCD-PR and soft PR. So both of them are not very likely to be in the first position, but by the time we get to the third position, they're about 70 or 80% to be the third best treatment or better. Then we've got the next three that kind of go together as well, SIM-PR, TEL-PR, and BOC-PR. Once again, they're not very likely to be in the first couple of positions. By the time we get to the sixth position, again, they're nearly 100% to be sixth position or better. And then finally, PR by itself is very unlikely to be anything but the worst treatment. And one thing to note about this, and again, it's different to the one that Chris presented earlier on, is in this case that they all will be 100% in the seventh position or better, because the 7 treatments. Okay, so I think this gives a lot of information about the treatment rankings, but of course it's always good to have like a one-number summary as well. So you can get that by calculating the secret. So it's the surface under the cumulative ranking curve. So this will be a number between 0 and 1. And 1 means the treatment is definitely the best treatment, and 0 means that it's definitely the worst treatment. So as we could have guessed from looking at the ranking graph, PROD plus ribavirin is identified as the best treatment with 0.97. And then PR, when it's rounded down, it's 0. So again, it's almost certainly the worst treatment. Okay, so then to move on to the second example, which is taken from a paper by Nikki Welton from Bristol, and they're looking at models for complex interventions in coronary heart disease. So there were 5 different interventions. And these are all given in addition to usual care. So the first one is educational, so educating patients about health risks. The next one is behavioral, so focused on actually changing behavior. The next one is cognitive, so changing the beliefs or the perceptions of the patients. And then we have relaxation, so things like yoga or meditation. And then finally support, so that's where patients come together and support each other in their trying to change. Okay, so there were 4 different modeling options explored. So the first one is the single effects model. So here, all psychological treatments are grouped as one, and there's no way to tell which treatments are the most effective. So you can either say psychological interventions work in general, or they don't. You can't rank the different psychological interventions. The next one, which will give you a little more information, is the additive main effects models. So it sums the effects of all treatments given. So we can get an estimate effect for, say, behavioral, and an estimate for educational. And if you get both of these treatments, you get the effect of both of those sums. And the next option is a 2-way interaction model. So it allows for interactions between the treatments, and this is possibly maybe a more realistic model. So say, for example, you were on the educational intervention and the cognitive intervention. So there might be some overlap there between changing your beliefs and being educated on the risks. So maybe getting both of these isn't as great as the sum of them both individually. So here the interaction would be a negative interaction. It can happen though another way as well. Like let's say you were on behavioral and you were on support. Maybe support is beneficial, but it might be hard to support one another, to support each other if it's not very directed. So maybe by having the behavioral intervention as well, there's more of a direction there, and then the benefit of the 2 components might actually be greater than the individual parts. In this case, you have a positive interaction model. And then finally, there's the full interaction model. So here, each possible combination of interventions is treated as a different intervention. So if you're on educational, behavioral, and cognitive, that would be a completely different regimen to educational, behavioral, and relaxation. Okay, so to choose between the models, the authors used the deviance information criterion, or DIC, and this is something that would be a built-in function in bugs. So in this case, the differences in the DIC were relatively small, so therefore the authors decided to go with the simplest model, which was the single main effects model and the additive main effects model. Okay, so here to present some results. So when we look at the single effects model, for the overall psychological intervention, they found an effect on 4 out of the 8 outcomes, which are all listed in the table here. So it had an effect on non-fatal myocardial infarction, total cholesterol, depression, and anxiety. So it's interesting to note that the last two, the depression and anxiety, are the two psychological outcomes. So the psychological interventions had an effect here. However, a lot of times you might think of primary outcomes as mortality, and the psychological interventions didn't appear to have a significant effect here. So that could be because psychological interventions just don't have an effect, or it could be because some do and some don't, and the ones that don't were watering down the results of the ones that do. So to find out more information about all of this, we'll look at the additive main effects models. So here we're looking at a table of the probability of each treatment being the most effective. So this is like the secret score I was speaking about earlier, but it just gives the probability of it being the best treatment. So for each one of the outcomes, I've colored the cell that has the largest probability of being the best. So we see that behavioural and educational come up quite a lot in this. And if we look at usual care, it's consistently down at the very bottom. So here it is showing us that it does seem like psychological interventions are beneficial. However, to bring it back to like a significant result, again, we're looking at where the credible intervals do not cross the line of no effect. There are only 3, which are the 3 that I've colored in the red text here. So it seems like, again, we possibly don't have enough power to detect all the significant results, or possibly. One thing to notice here is that the ones that are significant aren't necessarily the best. So let's say we look at depression, one of the highest probability of being the best is the behavioural intervention, whereas that's not significant, but cognitive is. So what's happening here is that the point estimate for behavioural is larger than the point estimate for cognitive, but there's much more certainty around the effect for cognitive. So perhaps if there were more studies on this, more studies available for now meta-analysis, then perhaps we could possibly get more significant results. Okay, so then just to conclude, so network meta-analysis is useful for exploring multiple treatment options, and there are a number of different options to explore complex interventions. However, as we've seen with the coronary heart disease example, sometimes there may not be enough power to detect the differences between the higher order interactions. And also the evidence may be insufficient to treat each unique combination separately, as we saw with the hepatitis C models. So the best option in each case will very much depend on the evidence structure, and the more evidence you have, the more separate regimens you can look at, and the more you can detect interactions between them. So it very much depends on what evidence you have, but hopefully these will have guided you and help you know what you could do if you're in this situation. Okay, so thank you very much, and I will pass you back to Chris.
Okay, thanks very much, Jay. So I just wanted to end by highlighting this workshop that we're organizing in August. So it's 16th and 17th of August here in NUI Galway in collaboration with the TMRN who are hosting this webinar. And the course is going to be run by Professor Nikki Welton, Dr. Deborah Caldwell, and Ms. Edna Keeney, who are all part of the School of Social and Community Medicine in the University of Bristol. Professor Welton and Dr. Caldwell are both experts in this area and have contributed to the development of the methodology in network meta-analysis. And they're also fantastic teachers. So myself and Jerry Malloy went to Bristol last year and attended one of their workshops, and it was a really fantastic experience. So it's a fantastic opportunity to come and learn more about network analysis and get a hands-on experience in conducting these analyses. So you can find out more by going to the TMRN website and or by contacting myself, chris.noone@nuigalway.ie is my email address. And it's €150 for professionals and €50 for students. Okay, so I think that's us now, but we have a Q&A session which Rachel is going to moderate.
Thank you very much to Chris and Joy for that. That was a great webinar. We have a few questions through. I'll just start with how well do you find NMA findings are accepted among the trial community?
Well, I suppose they're used quite a lot in health technology assessment submissions. So that's when different countries decide whether or not they will actually pay for these drugs. So they're checking, they may have a drug on the market already, and then they're wondering whether to pay for this new drug as well. So given that they're used there, that's a really real world outcome that people are putting a lot of faith in, that governments are spending quite a bit of money on. So I think that's a good indication that they are quite accepted.
And have you come across any negative preconceptions associated with this type of analysis, or uncertainty?
So I think the example that I presented right at the start of the network of analysis, that the headlines recently regarding antidepressants, that paper was heavily criticized in some areas, but not because of the network analysis approach per se, but because of the decisions on what trials to include. So I guess there was a lot of question marks about whether there is bias in the trials that were used in that network analysis, because a lot of them would have been produced by companies that wanted to sell these antidepressants. So that was kind of the main critique that came from that paper, and I think for most network analysis papers that the critiques generally lie on decisions around what trials to include, how those trials are grouped in the network, and the approaches that were taken to testing whether the assumptions of network analysis were met. So there is consensus that the network analysis is just as trustworthy as pairwise meta-analysis, traditional meta-analysis, but there is acknowledgement that more methodological work needs to be done to solve these problems of how do we decide how to group treatments, and how do we make sure that we're dealing with the assumption of transitivity in the best way possible.
That would actually lead me on to the next question, which is what are the current methodological challenges for conducting NMA? Because I did notice that, Joy, in yours, had someone else carried out the systematic review and you took the information from the published article, or you were involved in the systematic review yourself?
So it was part of one joint project. So there wasn't an actual publication from the systematic review, but there was a pharmacist who did the systematic review part. And then we worked kind of together, discussing the data, discussing how we should how we should group the treatments.
And did you find that approach better being involved in the systematic review from the start, or would you have just kind of gotten the data?
So I wasn't involved in it at the very beginning, but I think I think as much collaboration as is possible early on is good. Like, even if somebody says, well, I'm going to do a systematic review, and we kind of discuss what we're looking for, what outcomes, all that sort of stuff, and then maybe somebody else might go off and do that themselves, and then we come back again and discuss it. It's actually the same thing that Chris and I are doing right now. We're working on a project together, so he's done the systematic review, we're starting the data extraction, and that's sort of we're having conversations about that stuff.
Okay. I have just two questions relating to Stata, or Stata. just someone's asking for you to summarize the strengths and weaknesses for using Stata for NMA, and is multivariate network meta-analysis available in Stata?
To be honest, I've never used Stata, so I can't really speak that much to that. The reason I suppose why I don't use it, or why I don't see it as much in papers, is probably because of the fact that it costs. So
I've used it. Yeah. So the workshop went in Bristol last year was focused on and also the one that's going to be here in Galway in August employs Stata, and there's some very useful packages in Stata for generating the graphs you need, the network plots, and the different types of results outputs. I suppose the main difference between these approaches and say using bugs is that the Stata approach is based in like frequentist stats. So I suppose the kind of stats a lot of us would be familiar with, whereas bugs is based in a Bayesian framework. So you probably have more flexibility in terms of modeling approaches with bugs than you would with Stata. But Stata is more accessible. I think that's what it boils down to, really. Yeah.
And would you generally recommend Bayesian methods?
Yeah, I think they're a good way of doing things. I think that it encourages you to think about your model, to think about the priors on your model. It gives you a lot more control over everything. And I think if you look at a lot of the research in network meta-analysis now, and a lot of the guidance that you see in the technical papers, that they are using the Bayesian methods. So I think it's the best way to kind of stay in line and stay up to date with the kind of the current research.
Are either of you aware, has anyone done individual patient data network meta-analysis?
Yeah, I actually have, and I have an ISPOR poster available for that online. So there is a lot of benefit with that. One of the main benefits actually is figuring out about the different patient characteristics in the network, and whether they are, say, a prognostic variable, if they act the same way across different treatments, or if they are what Chris mentioned earlier on, an effect modifier and interact with treatments. Because sometimes you might get a treatment that works very well, I know, for maybe younger age groups and not for older age groups. So you can find out about those sort of interactions when using individual patient data. After you figured out that, there's still a small bit of benefit of using the individual patient data, but once you have it for like a couple of studies, it's not necessary to have it for the whole network. And there are a number of models available where you use individual patient data if you have it, and aggregate data otherwise. So I think that is probably the best way to go about it. If you have it for some, you should definitely use it. One other really good thing about it is that it encourages people to talk to the primary researchers of the clinical trials as well. And you get more of an understanding of the area, and maybe more insight into the problem and how the NMA should be carried out.
Thank you for that. There has also been a request that we could perhaps get a list of the references for the talk. Would that be possible?
Sure, yeah, that's no problem.
So there's one question here that said, can weighting or adjustments be applied to account for the differences between the studies? For example, in your hepatitis example, you grouped by duration. Can you adjust and add a frequency weight to account for the differences?
I suppose you can, but it does make it harder, when you have so many different interventions. When you say frequency weight, I'm not really sure what that is referring to.
Does that represent the differences in the duration?
But as in weight the outcome, as in change the.
Yeah. So Rachel, is that what?
I think what
based
is
on the frequency or on the weighting based on the duration of each. Is that what the question is?
I was saying if you get it 4 times as much, you give it 4 times the amount of weight.
Sorry, he's just come back with weight based on the duration. So how long they were taking the medication.
I'm not too sure because I don't know would you put the weight on the outcome? Like, as in, would you say that the outcome should be 4 times as much if they got it 4 times as often?
Well, I guess if they were just getting different dosage, what impact that would have?
I suppose the best thing to do would be to have them as separate treatments, but I think that would be infeasible in a lot of meta-analysis. I don't think I'd recommend weighting them differently.
It would also depend on the characteristics of the intervention itself, because, for example, we're looking at hypertension, and it doesn't really matter whether the treatment is 4 weeks long or 12 weeks long, or the action of the antihypertensive is consistent. You know, it doesn't take that long for it to reach a kind of a ceiling effect. So sometimes, even though there will be differences in the duration of the different interventions, modeling that wouldn't actually make a difference.
But perhaps if you came out and said that one medication was best, you're not really telling the clinician much information about what sort of dosage or how long you would have to tell your patient to be on that before they get the effect. You're just essentially saying that one is the best.
A lot of times they'd probably have a good idea of that already. Like, say in hepatitis C, they kind of, they test for the X-score after say 12 weeks. So they'd kind of already have that information. There might already be like a set clinical dose. I suppose after that, if there was a lot of uncertainty, that could inform future research, future clinical trials.
Could you network the different dosages once you found one was the best?
Yeah, you definitely could, or you could even just do a pairwise meta-analysis in that case. But again, it just depends on how much, how many different trials there are out there looking at it.
Okay, just another question here is do you know of any clinical areas for which network meta-analysis is currently needed? For example, a prioritized set of research areas suitable for this analysis?
I feel like it's useful in most clinical areas. I think maybe there's a lot of work going on in cancer drugs at the moment, looking at it there. I think that's quite important, and I think there's obviously a lot of new drugs coming out in that area. So that's one that kind of springs to mind, but I don't know if that's actually just because of the area that I'm in at the moment that I see that a lot, or whether it is really the number one area for it.
Yeah, and I suppose just from our personal point of view within our team, we're most interested in trying to apply this to behavioral interventions because, and also to particularly what we're doing in our project is comparing behavioral interventions to pharmacological interventions, where that's appropriate. That's a really interesting analysis because that will give kind of the kind of information that healthcare decision makers need about where do we need to invest in drugs, but that kind of research is already happening a lot, but there's not as much consideration of, well, where would it be feasible to actually take a behavioral approach instead. So yeah, we're really interested. We think it's a priority to try and develop methods for comparing trials of behavioral interventions and trials of pharmacological interventions. Yeah.
Just to note, I had come across a network meta-analysis in the area of hypertension, and they did come up with there was one pharmacological intervention which was best, and that they said that if any future research was done, that should be the comparative treatment, or that should be the so that should be the thing that things are compared to. So if you were going to be looking at behavioral interventions, you could perhaps focus on that.
Yeah, absolutely. And that's what network analysis is really useful for finding out these kind of, what's the new standard to be testing against. And then that can inform, it's not just about ending at the network meta-analysis stage, but actually network meta-analysis gives a much more scientific and ethical justification for the design of new RCTs.
I agree. So there's just another question here for, within complex interventions, is it possible to convert the disconnected networks to connected networks?
It would depend on that doesn't, I don't think it would make a difference whether it's a complex intervention or a standard intervention for that particular problem. And it's a really contextual problem that you have to look at the specific network and how it's disconnected to see if there's a way of joining it up, or if you can apply the methods that Joy mentioned, or whether it's better to just focus. Sometimes, for example, HICWA did a network meta-analysis to look at smoking cessation interventions, and they found that they couldn't join up certain parts of the network, so they ended up just doing 2 separate network meta-analyses. So yeah, sometimes you will just be forced to work by leaving the networks disconnected.
Okay, just one last final question, and if it was possible to include covariates in the analysis, for example, dosage, to account for different dosages between trials of the same drug, which I think we did somewhat cover, but to clarify.
Yeah, that is definitely something that, usually you would include covariates. Of course, one of the problems with network meta-analysis, and it comes back to just power, is sometimes you would look at covariates and then you do like a meta regression to check which ones are significant, and a lot of times you have a lot of uncertainty. So you might not be able to say this covariate is definitely influential, but you can still examine it and include it if, say, the clinician thinks that it is important.
That's great. Thank you, thank you to the attendees for all the questions, and thank you to our presenters for their wonderful webinar. I think we all found it wonderfully informative, and it was a great discussion also. So thank you very much for everyone who's attended, and we look forward to seeing you all on the next one. Thank you.
Thank you.
Cheers.
Bye.